I don't think I'm on here.
Hey, everybody. Can everybody hear me? Yeah, great. So we're going to go ahead and get started. We got a lot to pack into today's session, so I don't want to cut anybody off. We are going to start with introductions, and then we have 3 cases to discuss today. So let's see. Dr. Josh Carter, do you mind to start with this?
Yeah, I can. I'm Dr. Carter. I'm a psychologist and the program director for the Cabin Creek Clinics. And I've got about 4 people with me and 2 more coming. Turn the camera around.
Catherine Darby.
Lois Vance, care manager.
Debbie Jones.
Bailey Hendricks.
And I've got Dr. Wilkes and Jason Duncan coming.
Excellent. Thank you. All right. Ryan Morrison.
Hi, I'm Ryan Morrison, Medical Director for Cabin Creek Health Systems, Kanawha City Health Center, Medication Assisted Treatment.
Perfect. Thank you. All right. And Sarah?
I'm Sarah Sampson. I'm a psychiatric nurse practitioner with Camden Ongali.
Excellent. Thank you, Sarah. All right. Let's see. Brant Williamson. Oh,
Can you hear me?
we can hear you.
Yeah, okay, Brent Williamson. I'm a emergency room doctor in the Eastern Panhandle and at Mountaineer Recovery Center now.
Excellent. Thank you for joining. All right. Let's see. Jeremy Hirschler. Oh, you just walked away. Sorry.
Had to get the door. Hello, I'm Jeremy Hirschler, addiction psychiatrist at the Lakewood Center in Sheep Lake.
I'm Phil West, clinical therapist at Lakewood.
Perfect. Thank you both. All right. And Crystal?
Crystal Simpson, case manager with Summersville, Camden Family Health.
Great. Thank you, Crystal. I know you guys figured it out. All right. Beth Shelton?
Hi, I'm Beth Shelton, and I'm from Appalachian Community Health Center, and I'm our MAT therapist here.
Perfect. Thank you, Beth. All right. Dr. Aldis?
Hi, John Aldis. I live in Shepherdstown.
Great. Thank you. All right. Jeremy Sagan? Oh, we can't hear you. No. We can't hear you. But everybody, Jeremy is from Northwood up in Wheeling, and we hope to get his mic working here in a second. Thank you. All right, Megan.
Hi, I'm Megan Toscano. I'm the project assistant at WVU.
Perfect, thank you. All right, Amy Lively.
Hi, I'm Amy Lively, care manager at New River Health Association.
Great, thank you. All right, and Adina Bowe.
Hey, Dina, Charleston, West Virginia.
Great, thank you. All right, and then the Echo Institute.
Hello, I'm Bridget Quinn. I'm a program manager here at the Echo Institute.
Hi everyone, Ellie Cordova, replication manager at the Echo Institute in Albuquerque, New Mexico, and thanks for letting us join today.
Thank you for joining. All right, and so then here we have.
I'm Andrew Danko, the program coordinator here at WVU.
I'm Douglas Harvey, case manager for WVU Medicine.
Jim Berry, addiction psychiatrist.
And Caitlin Oettinger, project Echo coordinator.
Hi, I'm Mitra Mokashim. I'm also a project Echo coordinator. Hi, I'm Katie Chasson Downs, clinical therapist.
I'm Jay Mason, the assistant director for Project Echo.
All right, great. So if more people jump on, we'll introduce them as we go, but we do have 3 cases to start with. And I was wondering, Dr. Bowe, do you mind to start with yours?
Love to, because actually I have a big emergency I have to go run to.
No worries, we'll hold off.
No, I can do it. I like how I'm going first. Yeah.
Sorry about that. All right. Whenever you're ready.
Okay, so here we have a 28-year-old gentleman. We've been seeing him since about May of last year. and he's been on Sublocade. We inherited him on that from a program in California. So he is very compliant. He comes to monthly meetings. He actually sees my colleague, Dr. Naza, who couldn't be here today. He's also in an emergency. So the issue with this gentleman, he came to clinic last month and said, guys, I'm having this big problem. I'm going through withdrawal, even though I have Sublocade implanted. What's been going on is that he's been buying Suboxone from his friends. He said he took like 1 to 1.5 a day in order to prevent withdrawal. So this gentleman, when we saw him inside our clinic, he was in withdrawal. I mean, he was sweaty, he was agitated, his blood pressure is a little up, he's a little tacky, and he was asking us to do something. So Dr. Naza looked at his Sublocade injection site and noticed that for the first time ever, the injection that he'd been giving him monthly was still in his lower abdomen. And so he was concerned, like, hey, what's going on here? So he, at that time, was due for his second injection. And so what we did, we went ahead and gave him it in his, on his right lower abdomen. So this gentleman, he sort of is like a bodybuilder. He has he looks like zero body fat. And so we were concerned, like, well, is the problem him not absorbing his Sublocade because he has such low body fat, and Sublocade is a SC injection. So we wanted to bring this case to you all because we were not too sure if anyone's ever heard of this, if this has happened. Since this gentleman is definitely going into withdrawal now, I had to give him buprenorphine. So we called Indivior and asked them, hey, this has been going on. What do you guys think? And they were shocked. They were like, look, dude, our studies only show 3 to 4 months of Sublocade. The long-term studies are now under process. So we had no idea this could even happen. And so we wanted to ask them, well, okay, how should we go about looking at this case? And they had various suggestions, but not much. And I'm still actually waiting for a physician to contact me. I spoke to the clinical nurse, and then we also spoke to the Sublocade rep here, and she's been working really hard to get them to actually get back to us. So what if we did for him? Of course, we want to prevent relapse because he has a pretty extensive history of use. We put him back on Suboxone. We're going to monitor him weekly now instead of monthly because I was worried, well, if he has 2 Sublocade injections in him, I have no clue what's actually in his system, but I know he's in withdrawal, so I have to give him Suboxone. So we did that. So he's been doing okay. What we did, we contacted the general surgeon and we go, yo, House, please take out the Sublocade, take out the injections, give it to us in a sterile tube, and we're going to send them off to Pax Talk, our lab, and see what they think. We also spoke with the clinical pathologist here, and he said, I have no idea what to do about that. I've never heard about that. We're not trained in that. At this hospital, we cannot test for anything. So in terms of his workup, the things we're thinking, well, one, we have to make sure his liver is working. So we're going to get his LFTs. We have to make sure his kidney is working because maybe that can explain why the medicine is no longer working. And so we ordered that test as well. We ordered a buprenorphine level. And we're just kind of waiting and saying, hey guys, what help can you give us? By the way, he skipped his appointment today, so he did not get his labs. Yeah, so that's where we're at with that. And I would appreciate any feedback in any direction.
Thank you so much, Adina. I wanted to ask everybody out there first, do you guys have any experience with this? I know Sublocade is a kind of a new thing around here.
What dose of Sublocade is he on?
He was on 300. He could not tolerate the 150. Sorry, the 100.
Okay.
Yeah, and usually when we saw him, it had clearly dissolved. There was no remnant left. So now looking at him, he had these 2 honking injection sites, and I actually had him take a picture with his own camera since we didn't have like permission yet, and told him to keep it just in case we have to investigate this further.
Has anybody had any other trouble with anything like this? That's kind of interesting. Yeah, Brant. Oh, do you have to go? Yeah. Okay, no worries. All right. You guys have any thoughts?
Yeah, it sounds like it's more of a delivery problem than the actual drug problem, right? Because you're able to relieve the withdrawal symptoms when you give him the sublingual buprenorphine. So in my mind, it wouldn't be necessarily a genetic metabolism issue. It's whatever the problem is regarding the delivery with the Sublocade. And you have visual confirmation of that because you're seeing it all gunked up in his sub-Q area, right?
Yeah, that's right.
And so you know what I mean? So it doesn't sound like it really is a genetic or metabolism issue. It sounds like it's more of the mode of delivery issue. And I wonder is also if maybe there was a bad batch that it had come in, and be looking into the pharmaceutical company to find out the lot number of that batch and see specifically narrow down if there's something wrong with that batch. Because he's had this for a number of months prior, right? You said.
Yeah, a whole year.
A whole year without having any issue. It changed. And so that's the first thing that I come to think of is it the batch of this medicine that's the problem?
Okay. Now, in your opinion, if it was the batch, shouldn't they have heard different things from other users?
Maybe he's the first one using that batch, or maybe there isn't enough astute physicians like yourself, Dr. Bowe, who's actually pursuing this. And maybe they tried it for the first time and say, "Oh, this doesn't work for this guy," or the patient never came back because it didn't. That might have been the first time they tried it and said, "Oh, this doesn't work. I'm not ever going to go on this again," and just went back to the streets of using Suboxone or buprenorphine, or found another doctor to give them sublingual.
Okay.
You know, so you may be the first one that's actually reporting it, and who knows? Maybe you're gonna start hearing more of it.
Okay. All right. Thanks. So just call the pharmacy and track down the lot number and go from there.
That's what I would do, and then you've already been in contact with the company itself, and just say, you know, why don't you guys like explore and see if there is something wrong with this batch?
Okay, I will. Now, what do you think about since he had the symptoms? Are you all thinking then I don't really have to worry too much about how much bup is in his system? Because I'm thinking, boy, if this thing starts to work all of a sudden, man, I'm in trouble.
This is uncharted territory, really, because I would have thought, I'm right with you, is okay, now he's got these 2 lumps of buprenorphine deposited in his body that's just waiting to be released somehow. And what's going to happen? You know, you think about it, what would be the worst thing that would happen if he has too much buprenorphine in his system? I'll ask the group this. This is a good question to ask the group. So guys, what's going to happen if somebody like this quote unquote overdoses on buprenorphine? What if someone gets too much buprenorphine? What's going to happen?
I can't imagine there's much of a problem, but somebody else better answer.
Okay, so 1 vote for not much of a problem.
Jeremy.
Yeah. What else?
We can't hear you, but chat us.
Please use it.
Sorry, I know, I hate that. We've never had that.
The good thing is, since it has the sealing effect on the respiratory system, I'm not as worried about that.
Okay, so you're not worried about somebody going into respiratory depression with too much buprenorphine?
Not as much.
Okay. What else?
Bad constipation.
What's that?
You have bad constipation from this.
Bad constipation, okay.
Yeah.
Anybody else?
Any other ideas? Okay, so this is a good thought experiment then, because what I would expect if somebody has too much buprenorphine is actually you would precipitate withdrawal. And so remember, you've got that bell-shaped curve, okay? And so lower doses of the partial agonist is you're doing what we're doing every day by giving buprenorphine, is we're occupying the right amount of their mu-opioid receptors, and so that's helping with cravings and preventing withdrawal. Okay, you get a peak, and that's still fine, However, you go beyond that bell curve on the right side of the bell curve, and then you occupy the receptors, and then no longer does it act like a partial agonist or an agonist, then it starts acting like an antagonist. So that's what I would be concerned about, is if somebody's taking too much buprenorphine, you're going to actually precipitate withdrawal. They're going to demonstrate all of these withdrawal symptoms, and if we didn't know what was going on, we're thinking, oh, they need more buprenorphine. You're going to give them more buprenorphine while all that stuff's still being released in their system, and you're just going to precipitate more and more withdrawal. So I think what I would do is make sure he's educated about what's happening there, and that he may be experiencing more withdrawal if too much of that stuff starts leaking out into his system.
Okay.
Hi, guys.
Yeah. So we did think about that, but we thought that since when he bought the bupe from his friends, that made him better. We were thinking maybe it wasn't that. What are your thoughts on that?
No, so that's what I'm saying is, so right now there's a barrier between the buprenorphine that the Sublocade has delivered. There's a barrier. It's not getting into his system for whatever reason, right? Because it could be a makeup of the compound for whatever reason. And so he's in withdrawal because he is not getting enough buprenorphine. There's a barrier. Now his friends are giving him Suboxone off the streets. Okay, that's getting into his bloodstream and into his brain. That's hitting the receptors. Now, what happens if somehow for whatever reason, that barrier with the Sublocade breaks down, and all of a sudden it just starts working all at once, is what I'm saying is. And then he's going to have a whole bunch of buprenorphine. He's going to have double the dose of the Sublocade. He's going to have 600 milligram pockets, immediate release. And that could make him go into a lot of withdrawal.
I see what you're saying. Okay.
Yeah. So actually what we try to do is, I try to send them to remove the first implant within 24 hours. But he just wouldn't show up. Like, I tried to do that. I called the surgeon. The surgeon was okay taking it out, but the patient didn't show up. And then he showed up later when I was out of the office asking for Suboxone. So also we have some degree of non-compliance with this patient as well.
What about the QT interval and somebody getting a super therapeutic dose of buprenorphine?
So go ahead, I'm sorry.
QT.
Yeah.
I'll let anybody else address that if they have ideas.
Well, bupe with QT, I didn't think it
affected that. It doesn't,
yeah, so that's what
I wouldn't worry about that.
You have to worry more about the QT interval and methadone.
Methadone, yeah.
Not so much in the buprenorphine. But again, I think that driving home the point with this guy is, there may be a time where you're going to go in withdrawal, that those bumps in your skin are going to go down, and all of a sudden you're going to go into a lot of withdrawal. What you don't want to do is take more Suboxone at that point.
Right. Okay. You know, when I asked them, hey, you guys have ever heard of this? They were like, well, in our rat models, these guys some Sublocade not dissolve.
Yeah, like it is a mystery case.
Yeah.
Yeah.
So we're going to write it up.
Yeah. I've never had such thing with any other patient, but all the other ones are, a little chubbier than this guy. Abs to die for. Yeah, the first time I've injected him, he asked me.
Like Dougie.
No, even more fit, by the way. Sorry, Doug. Like, he really doesn't want me to inject it where it can affect the 6 packs.
Is that right?
I'm not kidding.
Well, or you could deliver 6 of them and make your own 6.
All right, thank you for your help. We don't want to hog up the time.
That was
no,
fun.
Thank you guys. Thank you both for presenting. And did you guys have a trajectory now? Check the batch and we'll go from there.
Yeah, that's excellent.
In the meantime, are you just going to give him sublingual Suboxone?
Right. And then the problem is this guy already has a supplier from work, because ideally I would have seen him today at 1, but I know he's buying from his buddy.
Yeah.
So who knows when he's going to come back.
Yeah.
Yeah.
That's probably the route going forward with him. I most likely would just continue with the sublingual. If he's
okay.
I would
Like,
suggest,
honestly, I wanted to see what's happening in there. So we want to send it for pathology, but he wouldn't let us do it. Because I know this is like a ticking bomb. Like he has 2 implants in his belly.
Poor guy.
I know. What if he eats like a couple more burgers, gain a couple more pounds, and these things start working again?
since he's a with programs, I'd suggest to maybe making it part of his treatment as a requirement to have those injections removed.
Yeah.
I would probably make that part of the treatment.
That's a good point. You could say, so we're worried about continuing to give you the sublingual Suboxone, and because of the reasons we just described. And so in order to do that, you really need to get this stuff removed for us to continue to give you the Suboxone.
Absolutely.
That's a great idea. I'll call him today and tell him that.
Yeah, well, he needs to show up first.
Well, we could do a call.
Together.
Thank you.
Thank you. We'd love to hear follow-up anytime you guys have
Got
that.
it.
Thanks, Nina.
Thank you, guys.
Thanks.
Is there any way, Sarah had a question. She was just wondering if there was any way it could be diverted.
That'd be a stupid question, but they're creative.
Yeah.
No stupid question.
I mean,
No, that's a great point. Is there some way that somebody could do their own surgery off of this guy, or he could do them himself and get it and do something with it? I don't know.
No, because when you put it in, the liquid goes to like this putty kind of thing.
Yes, the Atrigel.
Yeah.
So it should solidify. So technically, the only way to get it out per manufacturer description is by the blood flow in around it and taking the substance from this implant. That's it.
Yeah, so they can
cannot suck it out.
but you can't use it.
Okay, that answers that.
Yeah, unless on the black market they will know how to do it.
Absolutely. Yeah, the dark web. They do. They figure it out.
All right. Thank you, guys. Okay, so we have 2 cases from Lois and Dr. Morrison. Are you guys cool to start those? Do you have a preference of which one you want to start with? Nope. All right.
Okay, so we got a 30-year-old male Medicaid patient that had been with us with sobriety for, wait a second here. This is a different one than what I thought. Okay, but he had been with us and sober for over a year, with good compliance, never had a problem, never had any concerns at all.
I think that's our other case. This is Corey.
Yep.
I can pull up the other one. Here. You guys see that one? 821?
I think it's actually going to be both cases have the same starter stories, but we'll do this one that you got up. 38-year-old then, female. That's correct. Yes. Okay. I know who this is. So 30-year-old female with also a year of sobriety, never had any problems, just a great patient, very compliant, very motivated, very helpful to other patients. We want to do everything we can to retain someone who's made so much progress in recovery as this individual. I think they started with us around 2017-ish. They've been in the program closing maybe on 2 years. But recently they've been under a lot of stress at work. They've been coming in to the group very, very like trimmery, but saying that, oh, I'm just really stressed with work. But our prelim drug screens are still normal, and we don't have any suspicion of any wrongdoing. But we recently got this really upgraded drug screen option through LabCorp. This is specifically designed for MAT that just does a really good job of detecting everything. And it was just we send it off like once a month. We just like a comprehensive, and it came back that there was a very low level of methamphetamines, like 300, 400, but it so we have a prelim in-office cup drug screen, but we also have, whenever we send it off for this comprehensive, they do a prelim and then a reflex to a GCMS confirmation, and both their prelim and their reflex were positive for methamphetamine use. So, so even though we didn't really have an indication to reflex the test from the cup, we ended up detecting very low level methamphetamine, which was concerning. At the same time, so we have, a recent screw up on my part where I've been trying to move towards softer discipline, or reduce the increase in the level of care for patients like this who may have had a slip up, but it's and been dishonest about it, but who have got a very long time in recovery and who have been very good for other patients and are so the key question is, do you ever take patients like this and put them back to weekly groups, or is there a like a hard line no? If you weren't honest about the use, does everyone consistently send those patients to AP coat? We had the recent screw up I had was I had a patient where I did not send them to AP coat after an unreported use like this, and I end up regretting it later. And I brought it up on one of the echoes, I think 2 weeks or a month ago, and the answer on that one was that you guys would have moved them to AP coat. So the core question is, do you ever deviate from that, even if they 5 years sober, one slip, they didn't tell the truth, goes to AP coat? Or are you guys playing with that a little bit, individualizing that some? And the other case I thought was going to be similar. I'm not sure on that. So, but this is something that is a particular problem for me because I'm running into a lot of methamphetamine use, and my AP mat is full of methamphetamine users. And so if a person is struggling with a single slip up on methamphetamine, and where we have the group therapy, I end up putting them around a bunch of other people who are struggling with methamphetamine, and I feel like it puts them into almost a harm reduction category when I really had them into recovery, and I just needed to get them back into recovery quickly before they ended up just sort of going down the rabbit hole. So, but at the same time, both my AP mat and my standard groups, they're all groups have very little individualized care. I take pregnant women individually, but otherwise I try to keep everything in groups. And because I have it in groups, every time if I would break a rule for someone, everyone would know that this person, I'm playing favorites and I'm letting her just get weekly when she should go to 3 times a week. So I wanted to hear your all's thoughts on how you guys are doing it these days, these situations like this.
Thank you.
Thank you, Dr. Morrison.
Well, I think it might be helpful before we go into what we would do for the COAT program. What are people's thoughts about what they would do if they were seeing this person even individually, doing a MAT with this person? What would you guys do if you had, or what are the thoughts if you had somebody who tested positive and didn't admit use and you got the confirmation?
Okay, so sorry I had to step up for my emergency, but I just escalate the level of care because they've not been honest. So if I were seeing them, if they were coming once a week, they go to twice a week, and we work on that and try to identify what's problematic, why are they returning to or using methamphetamine? Because we do see this a lot.
Yeah, thank you, Adina. Anybody else? I know you all do it.
how about even going before deciding what to do? How would you go about having the conversation with the patient about what you're finding?
You mean in terms of recognizing the use?
Yeah. Number one is, I mean, I would be really interested to know what's actually happened. You know, what has led her to start to use if she's been doing very well for a long time, and why is the behavior changed now, and what are some of the factors that have influenced that? But you know, just curious about how people typically bring that information to the patient when they find that it contradicts what they said.
I know what I've done. Grab the last like 3 or 4 drug screens and bring the one that is positive and sit with them and say, hey, I find something so interesting here. This is positive in your urine. Can you tell me about that? What are your thoughts? And usually the first response is, no, that's not, how could that happen? No way, never. Then I say, well, sometimes there are mistakes, but our lab is pretty specific. And I know this might be a hard thing for you to talk about, but I want to address this. And usually when you're kind of nice and like, you're not going to get in trouble, just tell me what's going on. We've had good success with that and kind of open up, hey, the ex-boyfriend came back around, or I had to go babysit my grandkids and so forth. And then we kind of just troubleshoot from there.
So I'm actually curious, Ryan, what did the patient say whenever you addressed this with her?
Oh, we took advantage of the reality that she's a monthly patient presently to talk to you guys before we addressed it with her.
I think Adina's suggestion is important, letting the patient be responsible for telling what's going on and responsible for the outcome of the decision. If the individual admits to screwing up, has done extremely well for a long period of time, some sort of halfway measure rather than calling this a complete relapse failure, somehow let the individual, the patient, have some responsibility here. I think that's a good idea.
Sometimes it helps to differentiate between a slip and a relapse along the same kind of theme that you were talking about. So, is this like a one-time event or is this an ongoing problem?
Certainly. Any other comments, insights, questions? I'm sure we've all seen the similar.
Yeah, Dr. Morrison, I just wanted to comment that, yeah, I probably would do the same thing that Adina had said about bringing her in and talking to her, finding out the circumstances. And I try to individualize the treatment, like to each circumstance and each person. If one person has more barriers in regards to transportation, if they miss or something of that nature, I try to be a little bit more lenient. But also, that does bring some issues when you're in the group and the group finds out. And then you have like, 10 patients that are a little upset. But, in that case, remind them that the treatment, we go by the policy, but try to take into individuals' circumstances into consideration. But if you figure out how to handle that one, please let me know. I've had some big issues with that.
Yeah, thank you, Sarah.
Dr. Morrison, I think even the way that you have this written up in your case presentation, you say, what should our plan be to better care for this patient? And I think that's the thing to communicate to her when you see her next, either in person or on the phone, of, this is about us being able to provide the best care for you. And so we want to be able to meet your needs where you're at. And the tests are maybe showing that she's got some increased needs that you're wondering if you can meet for her at a monthly level and that be kind of the bridge to have that conversation with her. Do you have a bi-weekly option at your clinic? Or is it just weekly and monthly?
We can't hear you.
Sorry, I couldn't click on my microphone. I do have a bi-weekly option. I never imagined that would be an option for her. I was thinking this was looking at weekly versus AP mat 3 times a week. So to hear that bi-weekly is an option, I'm actually very relieved. So I think I just misunderstood how you all were doing things with your care escalations. I thought there was a dishonesty, like double whammy on that, so you wouldn't get by with just one escalation of care if you were not honest about your use.
Totally.
So Ryan, I just want to check with Caitlin before I spoke. So I can tell you what we would do to handle this type of situations. Of course, we'd want to address this with the patient, the positive confirmation on the drug screen, and find out what's going on and everything. See what she says. Is she going to be honest with us? She's still going to be dishonest and stuff. And you want to have that conversation with her. What would happen, no matter the outcome, you have the confirmation, you know that the patient had relapsed at some point. So since she's in a monthly group, what we would do is drop her down to a bi-weekly group and start back in that clinic. So that is still intensifying her level of care because we're going to see her more often. We're still going to see her twice a week, where she's only been seeing once a week before. And we would have her day start over from whatever time the relapse was, and hopefully she'll admit to that.
Was she in, was she in once a month?
She was in a monthly group,
Right,
correct?
okay.
Yeah. So how we have structured our program with that, so if a patient's dishonest or needs a higher level care that's in a no therapy group, we drop it down a tier to a monthly group. If a patient's in a monthly group that's dishonest or needs higher level care, we'll drop them down to a bi-weekly group. Bi-weekly patients down to a weekly group. Weekly patients will start seeing twice a week, and then 3 days a week, and then residential and so forth.
And this is about communicating, not that this is a disciplinary decision, but that you want to help provide her the best care that she needs right now. And if there's been one slip on methamphetamine, is there a potential there's been others? And so you want to be able to give her more time, more treatment.
Right. Because you need a patient to be honest with you on what they're doing outside of their treatment time with you. Because if they're in a monthly group, they're going 27 days without seeing the provider. So you're relying on them to be honest with you so that you can continue treating them. And if a patient's being dishonest, then how are you going to treat that patient if you don't know what's going on?
I appreciate what you said and the other folks saying about recognizing when we make a decision with one patient, that can affect what's going on with the other group members. And so we have to be cognizant of what's kind of best for the patient and what's best for the group.
I, in fact, had another patient very recently with a post 1 year return to use that was very upset that he saw that that he was honest about his use when he returned to use, and that someone else had been dishonest, and there was not really a differentiable difference in the amount that we escalated the care. I think that was bothersome to him, and so that's why I was unsure how to handle it. So and then there's dishonesty is such a spectrum. We get this lady, I suspect that she will admit to us that she did it once we confront her. And so I guess we could say, well, she was honest after she got caught. But we've also had people that never admitted, and they say, I don't believe in your science and your drug screens. And so my overall impression, though, is that right now, there's not a protocol-driven distinction any longer with the COAT model between how you handle dishonesty and honesty with regards to reporting drug use. But there may be some individualized variation. Is that correct?
No, we're still pretty we're pretty operational in how we deal with that. It's dropping them down one of the phases to a higher level of care. It's not going all the way down to what you were thinking back to the AP code necessarily. But if for anybody who is dishonest about the relapse, about use, then we will drop them down to a higher level of care.
But if we have a patient in a monthly group that is honest about a relapse, we won't drop that patient down to a higher level of care as long as they're still doing good and they can get back on track. Yeah. Now, if they relapse consistently after we see them 3 times and they have relapsed all 3 times, then yes, we will increase their level of care because it's not a one-time relapse. So if they're honest, then we'll leave them in that monthly group and we'll continue seeing them, making sure that they get back on track. But now if they're dishonest and we have to catch that, and then yes, at that point we would drop them to a higher level of care.
I think that's the part of my game I need to beef up is learning when someone's been honest. It's not like I've had a whole lot of people honestly tell me they've used again after a year. It doesn't happen every day. But when they do it, I need to maybe get a little in practice to say, you know what, we're just going to keep you in monthly anyway. And we think that's appropriate for you. But I haven't been doing that. So I think I need to set that example.
Oh, okay. I didn't know that. So has it been your practice typically? And I'm curious to know what the practice is of other folks, whether it's code or not, the code model or not, is if somebody does admit to a relapse, do you automatically increase the frequency of the treatment?
So Jeremy, okay, Jeremy wrote me a chat. I just had to take a second to read it. So given the new, more comprehensive testing protocols instituted, there may be more patients in the same boat. So maybe announce the change to the patients and give them that opportunity before initiating everything. Definitely. Thank you, Jeremy.
So with our patients who admit that they've relapsed, I don't necessarily escalate their care the first go around, but if they continue to do so, yes. Now the issue we're having with even that though is transportation, right? And so what we would do, if I have someone come into IOP bi-weekly, I would just give scripts to get them to the next meeting. And then they wouldn't come to that because they can't because of transportation issues, but they might come to the weekly. And so, so what I've found is some patients in that situation, they're missing some of their Suboxone because they can't come often.
Right.
What they do in that case, they buy off the streets.
Yeah.
Right.
I'm sorry it's a little interrupty, but I know from SOR, and everybody in here is working with SOR, they've been paying for a transportation assistance program. Has anybody been able to take advantage of that in the counties? I think they're in most of the counties that we have here. Has anybody been able to call? All right. I'll check in with them and I'll give you guys all of that information and stuff.
Yeah, maybe Andrew.
That would be awesome because everyone can get here once a week, but 2 and 3 times a week, that's different.
Yeah. The representative I spoke with, they've been working with public transportation, but neighboring counties are meant to help other counties if they don't have it. And so they're meant to be able to schedule to get your patients to their programs. This is specifically for MAT or opioid related matters. So it really should be being used by everybody here. I know you guys probably didn't know about it. I just found out a month ago. So
you guys are familiar with Logistic Care, correct?
Nodding.
Yeah, that soup gets my patients.
Okay, so yeah, so that's another means of transportation. Definitely run into some bumps in the road, but as long as there is an appointment in the system that they can verify that the patient needs to go to, then they typically will provide transportation to that appointment. So whether it's billable or non-billable, as long as there's something in your system that Logisticare can call and confirm that the patient has an appointment, then they'll bring that patient to that appointment. They typically need a 5 business day notice, but they can do 24-hour urgency notice. And if you tell them, or whoever they call to confirm the appointment, if they tell them that the patient has to come to this appointment in order to receive medication, then that should count as the 24-hour urgency, and they should bring them to the appointment.
Dr. Morrison, when you do talk with your patient about her drug test, I recommend that you wear the shirt that you're currently wearing that says, "Let's settle this" at the top.
Like a doll.
Like a doll.
Love it.
I think that would be a good sort of just icebreaker for her.
That's true.
I can actually present the other case like in a sentence because it's very similar. It's just a 30-year-old guy with a THC level of 128 after he's like 400 days sober. When we did ask him about it, he said, well, my downstairs neighbor been smoking a lot of pot. So historically, we've been told up 128 too high to be incidental secondhand smoke. So no, this is a different case than the one I was thinking of.
Okay. You can hold
Well,
it.
no, wait.
You got to me, patient.
I was going to say.
Yeah, this is another one. Now, I thought we were going to present, but yeah. So this is a different guy, unrelated to the one I just presented. But anyway, for the one I just presented, that guy, you would probably just leave him in monthly, right? THC of 128 has a shady story that doesn't hold up, but it's a one-time deal.
Oh, I missed.
So how much time sober is he reporting?
Like 400, 500 days.
And he has THC in his system?
Yep.
And he's not admitting to using?
Oh, he admitted his downstairs neighbors are smoking a lot of it.
So that sounds very questionable to me. Dr. Barrett can chime in on this, but that sounds very questionable to me, and it sounds like he's being dishonest.
Okay. So you would take him to biweekly then from monthly.
When we notified him, though, of the test, he came in the very next day for a voluntary random, and we sent that out, and it was negative.
Oh, really?
Yeah.
How long after that first test then?
It was probably,
weekish.
yeah, a week or so.
Oh.
Yeah, maybe 5 days.
Okay. So, there are a number of gray cases, and this certainly would fall into the arena of being somewhat gray, is if it was a small level and you tested him again and it was negative, he's had all that time. You guys don't have any other red flags or concerns, right? That he's not looking any different, he's not sounding any different, there's no other markers that would indicate he's resumed using, I'm assuming, correct?
Right.
Correct.
So there have been times when I've said, okay, this could very possibly be an error, and we will give this to you as like the assumption that innocent until proven guilty in this instance. Just know that we're going to be upping our level of monitoring more frequently now. And so because this has happened, because we're kind of worried about you and what this may mean for your quality of life if you do resume using again, we're going to try to help protect you by having you maybe come in randomly and check on you more frequently than we would other people for the time being.
We've actually had him come in at the end of last week for a repeat random, and it was fine. Yeah.
Yeah, but and that's excellent. But what I'm saying is to at least notify him that there's just a greater level of attention going to be paid to make sure that he's safe, and that may mean coming in randomly between visits, monthly visits now, more frequently than he would have otherwise. And so then if he is faced with a situation where, oh, I'm going to smoke a bowl or a joint with my buddies when they come over on Friday night, I know that there's going to be a greater potential contingency there that I won't use at that point.
Did you guys have any other questions about this, the second one, the one-liner? I know a lot of people have questions about this, so I want to make sure we address them if they have them.
I have a question about THC monitoring, using creatinine adjusted levels of THC and how variable adipose release of THC is in someone who claims they're abstaining but still getting variations in levels. What do you think about that?
Does the group have an input on that one?
Yeah, I was thinking like for the chronic users, that can certainly be the case. You can have it go down and then all of a sudden, hey, there's something there. But if you look quantitatively at it, it should be a little bit, it should be less overall going down. Now the acute users, no, I would think they're actually using more, not just redistribution from fat.
Yeah, if the guy had 700 plus days, right, you wouldn't expect that THC to be left in some fat store until 700 days later. That then automatically would be released somehow. Unless he joined the gym of your other patient, Dina, and was getting a zero fat.
I have a question for the group, right? How much weed people around you have to be smoking if you're in a car with them in order for it to show up in your system?
It's up or down.
Thoughts? I think we've talked about this once before.
So there have been studies that have been done back in the like 60s or 70s where they put a whole bunch of smokers into a phone booth and a guy who wasn't smoking. And I can't remember how long they were all in there together, and then they would test them afterwards. Can you imagine getting that through the IRB these days? And the guy who was not smoking and was just getting the secondhand was not testing positive for THC. Okay, and so I never would buy the secondhand smoke story from one of my patients. And again, I couch it in terms of I have to go by what the evidence is, and have to assume that if you're positive for whatever reason, those are red flags to me that things are potentially unsafe for you. And so if that's the case, you just got to understand, then you can't be driving around with other people who are smoking. And if we see it in you, we have to assume that it's actually getting into your system, and therefore it's just as dangerous as if you were smoking it yourself.
Yeah.
Right? And these are the contingencies in place. If we see it positive in your urine, this is what then takes place because of that. Now, I have been wondering lately is, with the THC content in today's cannabis on the streets being so much greater than it was, 15, 20, certainly 30 years ago, would those studies change today because of the concentration of THC that we see now? So is there more likelihood that people could get high THC concentrations just through secondhand smoke than they wouldn't have back in the phone booth days?
James, I also wonder too, the technology back that many years ago for THC was certainly nothing like it is today. So this test may have been negative because of the inadequacy of the testing systems.
Got it.
Also, I'm told the THC is way stronger now, so maybe less secondhand smoke is needed.
Well, that's what I'm wondering, right? Because I know for a fact that the THC content is so much higher that there may be the greater likelihood of getting contact buzz, if you will.
And also the vaping, yeah, I don't know if that makes a difference if it's combusted or vaped for getting secondhand high.
Yeah.
So are we gonna have time for this other case, or are we out of time?
I don't think so. Do you guys have a question to ask about it, or would you be comfortable doing it at the next session?
Yeah, it's not a rush. I want to just give you guys a follow-up for some feedback I got on a recent echo. There was a woman with leg swelling that I was afraid of a Suboxone allergy, and I was advised to try Suboxone tablets. The pharmacist thought I was crazy. Suboxone's not going to work in a tablet if it doesn't work in a film. He thought it worked. The person's swelling just disappeared. But now the follow-up problem, everybody in my clinic is suddenly saying they have swelling when they don't, and trying to like put their socks on tight so they can get the tablets.
Yeah.
That's awesome.
Yeah.
That's good. Knowledge.
I really appreciate everybody chiming in and sharing today. I know we kind of did 2 cases in one there, but we all had a lot of good conversation about communicating being the big thing with your patients and talking to them. So thank you all. We have just about 5 minutes left. Does anybody else have any questions or urgently they need to bring up?
I do have a question. Jim, you just went to AAAP, is that right?
Yep.
The annual meeting?
Yeah.
Do they have anything to offer new for methamphetamine use disorder?
Nothing new, just the things we already know as far as really mostly psychosocial therapies like contingency management, CBT, are the most effective treatments we have. There are some possible medications that are considering down the pike that might be helpful. One of which would be actually combining, maybe mirtazapine and naltrexone, together. Otherwise, it's just anecdotal stuff. Kind of what I do is giving mirtazapine. It seems like some other folks have had success with that as well. And sometimes bupropion as well. Continued investment by NIDA in a vaccine for both cocaine and considering methamphetamine too.
Okay, thank you.
Have you been putting the Wellbutrin with the Remeron together? And how do you tell them to take it, the Remeron?
Yeah, I tell them to take it the way I would take an antidepressant, exactly the same way. Take it at night and 1 dose.
I would just tell you to, as you push Remeron doses, remember at doses over 30, it can be activating. So usually I switch after that.
Yeah, so for those non-psychiatrists out there, doses under 30 can help with sleep at night. And then once you start getting, this is kind of strange, it's one of those weird mechanisms. Once you get in the higher doses, it can be more activating and therefore not necessarily good for sleep. So I usually give them 7.5 or 15 milligrams and see how they do with it. If they say, oh, it's helped my cravings and my sleep, then great. If they say it really hasn't helped my cravings, then I'll go up to 30 milligrams and see how that goes.
Cool. Great, everybody. I had one last question before we end. Our next meeting is scheduled for December 23rd. I wanted to make sure if clinics would be open, if you guys would be here. I certainly don't want to cancel. If you guys need it, want it, I'll be here.
Okay, our clinic is closed that week.
Okay. Anybody else? Input?
We're open, but we're going to basically have every MAT patient in one day to get them in for Christmas.
Okay.
Oof.
All right, Camden, Northwood.
We're open, so we'll be here either way.
Okay. All right. I will, okay, great. Thank you, Jeremy. So I will send out a question in the email. I know I've gotten your guys' input, but if you can encourage other people, if you see them, to just respond so we know what to prepare for. But all right, that's it. Thank you all so much. Those of you who presented cases will get those notes and we'll see you all later.
Thank you.
If I don't see you, happy holidays.
Yeah.
Bye.